So staged procedure in congenital heart surgery. What I'm going to talk about is the univentricular heart. So all the other lesions that you see listed here in congenital heart defects have two functioning ventricles. And most of the time we do want to do a full repair on the biventricular patients rather than do a palliative procedure or a staged procedure, except for the univentricular hearts. Basically, these univentricular hearts, you've got one ventricle that has to pump for two beds, the pulmonary and the systemic circulation. And we have to figure out of how we can get them to adult life so they can actually survive a fairly normal life. So univentricular hearts, they're like a double inlet left ventricle. So there's no right ventricle, hypoplastic left hearts. So some of them can come with increased pulmonary blood flow, which needs a different initial management compared to the ones with restricted pulmonary blood flow, who are dependent on prostaglandin, as we spoke earlier. And then what we need to do is stage them till they get to the next level, which is the bidirectional gland and the cavopulmonary anastomosis. That is the final outcome to get them to adult life. There are different anatomic types of single ventricles, as you would see here, apart from the hypoplasia of one or the other. But you can have actually a double inlet left ventricle, you can have a double inlet right ventricle, and a double inlet intermediate type. So there could be also a ventricle that we don't know whether it's a right or left ventricle, or it can be an absent right atrioventricular connection. So there are a lot of forms of those lesions that can be, and each one of them will have to have a certain way of staging until we get them to adult life. So what we do is a palliative procedure versus a definitive procedure, because even a Norwood procedure, which is a big operation, it is still a palliative procedure because we're only getting them to the next level or the ability to do the next surgery and get them to separate circulation. So it's indicated whenever the total correction is not feasible and dividing that ventricle is not possible. Temporary treatment for a compelling clinical condition, or we have to address obviously a certain pathophysiological condition. So there are two types of palliative procedures that we go through. These are the ones who are needing extra source of pulmonary blood flow. That's what we heard, the systemic pulmonary shunts or the PA banding. And those are the patients, these are the different anomalies that have restricted pulmonary blood flow that needs a shunt, tricuspid atresia, pulmonary atresia, heterotaxy with pulmonary stenosis, or atresia, tetralogy of Fallot, and LTGAs with pulmonary stenosis and neonatal Epstein, that these ones need an extra source of pulmonary blood flow. Pulmonary atresia with intact ventricular septum, when you have the right ventricle hypoplasia, which is not adequate for a circulation to, or the pulmonary circulation, we need to augment that with a shunt. Now, it's really important to understand that the shunt, despite that it looks like it's a simple procedure, it's just a tube between the artery and between the systemic artery and the pulmonary artery. But here, this is a lot of physiology that goes into it, because as you know, the resistance and a flow through a tube depends on the diameter, the compliance, as well as the length and the differences between the two pressures. So this is where the mortality of a BT shunt, despite that it's being a simple procedure to do, can be substantial if these parameters not taken care of, and you're losing your grounds, or the baby's grounds, with either an imbalance on resistance of the systemic versus the pulmonary. And once you have one over the other, then what's going to end up happening is that the patient either is going to become so blue with a lot of systemic flow and may arrest because of severe cyanosis, or become so pink and have little blood going to their body, and they get acidosis and a cardiac arrest. So either ends will cause a cardiac arrest. And that's where managing these becomes really important in the first 24, 48 hours after instituting a BT shunt. When we have unrestricted pulmonary blood flow, obviously this is in these lesions, tricuspid atresia, double-ended left ventricle, heterotaxy without pulmonary stenosis, tricuspid atresia with transposition, and LTGA without pulmonary stenosis, and a VSD, arch hypoplasia with complete AVSD or VSD thought to be unrepairable in the newborn, because we do actually repair most of the VSDs with coarctation, as opposed to a pulmonary artery banding or a palliation, or we don't stage them, as a matter of fact. Again, when we put a pulmonary artery band, it's the simplest procedure you can think of. It's just basically a silastic band that we put around the pulmonary artery. But you got to remember that the circumference is the radius times 2 times pi. So changes in the circumference of this pulmonary artery will substantially decrease or increase the flow of through that vessel. That means that you're doing actually an acute pressure overload in the ventricle. And if you put a loose band, you're going to have high pulmonary blood flow and congestion, which means that you're not palliating the kid well. And if you put a tight band, this is an acute pressure overload in the ventricle will fail, and you have a low cardiac output and desaturations, which causes a cycle of acidosis and then cardiac arrest. So again, palliative procedure for single ventricles, they look simple, but they can have substantial morbidity and mortality after the initiation if the physiology is not understood very well. So flow to the systemic and pulmonary circulation are dependent on the resistance of each vascular bed. And therefore, the saturation itself is not always indicative of how much. It gives you a direction, but it could be misleading. And you want to keep the QP-QS, that's the pulmonary and the systemic, 1.5 to 1 is optimal. And what you want is to keep that baby not ventilated. And even if you have to exercise the least of PEEP, because you want to preserve the physiology and the interthoracic pressure, that it's not so high, so the venous return, all the other factor does not affect the ultimate mixing of the blood. Other critical parameters to watch: the mixed venous, that tells you the cardiac output, the lactate levels, as well as the near infrared spectroscopy that we do it in all babies in the pediatric ICU. So if we look at a shunted circulation, let's say this is the Norwood, which is stage 1 procedure, where we augment the arch. We do something called a DKS, which is, I'll give you a picture of that a little later on. But then the blood is either going through a BT shunt from the innominate artery to the right pulmonary artery, or going from the right ventricle to the pulmonary artery. What we have is saturation is around 80%, a QP-QS of 2 to 1. Then we move into the second stage. This is done in the first few days of life. Then we do around 3 to 6 months. We do the what's called the Glenn procedure, or bidirectional pulmonary anastomosis, where we anastomose the SVC to the right pulmonary artery. We take it away from the right atrium. Now you've got the primary blood supply to the lungs is through the SVC only. So the upper half of the body is into the pulmonary arteries. And that would give you a very similar saturation, but the QP-QS is 0.5 to 1. And then we bring them up to the final separation of the two circulation. We divert the IVC into the pulmonary circulation, and then we have a totally separate circulation. The venous is going by pressure or by gravity on the right side, and the single ventricle, whatever that be, it's the right or the left ventricle, is actually pumping to the rest of the body, and the QP to QS at that time is 1 to 1 if we do not leave a fenestration, and I'll show a picture of that. Hypoplasia, hypoplastic left heart is also in spectrum. So if we were So if we look at this diagram, you could have actually, so the flow from the right ventricle goes up to through the pulmonary artery, through the ductus, and back through the ascending aorta to supply the coronary arteries because there's aortic atresia and the left ventricle is not being supplying at all, versus a form of Schonn's complex, which only there's just smaller structures on the left side. And these are two different ways of managing them. Dr. Ehrenberg has gone through the initial management of those patients, and we've discussed that before. They are integral, and it's important to get them. So what do we do for those with the patients with hypoplastic left heart? The traditional Norwood is the first choice. We have something called a hybrid procedure. It does have it can be indicated in high-risk procedures, especially if they have non-cardiac lesions that needs to be taken care of, or we're waiting for it to get better, genetic syndromes, or if you have a poor right ventricular function that we believe it's not going to be sustained, it's not going to stand that big operation. The third option is obviously a transplant or a primary transplant. So the DKS, as we call it, Damas K Stansel, is basically a communication between the ascending aorta, which is tiny. Sometimes it's only 1.5 millimeters, and it's actually smaller than the actual coronary arteries, and between the pulmonary artery, which is huge. And this is really the Achilles heel of this operation. If this connection is compromised by any means, then you will not have a functioning ventricle, and that's why the initial mortality of these procedures was around 30 to 40%, and luckily now we have actually improved the techniques and we have a mortality of less than 5%. As a matter of fact, we have not lost a Norwood for the last 4.5 years at the Cleveland Clinic. So this is the Norwood procedure, then we move to the Glenn, and this is the Fontan. The hybrid procedure is, as I said, in certain indications, we basically put a stent in the ductus arteriosus to keep it open so we don't have to keep the baby on prostaglandin, but then we have to band separately both branch PAs with a PA band to limit the flow. So you have got one ventricle that pumps to the body and to the lungs. The lungs is restricted with these bilateral PA band, and then you have flow both way, backward to the head and forward to the rest of the body. And this is only in certain indications. And then we move to the Glenn circulation, and we have to always watch the QPQS. The Fontan is the final stage of a staged procedure, and this is basically the extracardiac Fontan. Now, this is the latest version of the total cavopulmonary anastomosis that we do. The Fontan has gone through multiple stages of evolution, and this is the final, what we believe is the best one, where we put in a Gore-Tex tube, which is very similar to the size of the IVC, from IVC to the pulmonary artery outside the heart, so we're not actually interfering with any scars in the heart. We're not opening the heart. It's all extra cardiac. And when the initial Fontan was brought about and published in 1978, these are the 10 kind of commandments which felt that if it's not met, we should not proceed with the Fontan circulation, because you really have to have a low pulmonary artery pressure, you have to have no obstruction, you have to have a small atrial size. Now it doesn't matter to us. So all these have been literally violated, and we have actually done Fontans with each one of those not being there. And currently now it's a little different how we look at them. What you always need is a low transpulmonary gradient. Otherwise, you cannot proceed to a Fontan. You want an LV in diastolic pressure of less than 12. And even that is questionable, because we need to see what is the cause of that LV dysfunction or whatever ventricular dysfunction. You have to have an unobstructed ventricular outflow tract. Even if it is present, it is addressable surgically, then you need to address it at the time of Fontan. You have to have a reasonable systemic ventricular function, at least reasonable. We're not saying it's normal, but at least something that is okay, and a good systemic AV valve function, whether that is a mitral or tricuspid or a common AV valve that needs to be repaired, and they do represent some sort of an abnormality sometimes that needs to be addressed. Sometimes we have to replace them. Most of the time we're able to repair them well, and you have to have pulmonary arteries which are not obstructed with a low pulmonary vascular resistance of less than 2.5, with units and unobstructed pulmonary venous return. These are the areas that we look at. We always have to make sure that this is happening. Otherwise, you have a failed Fontan. When Fontans fail, they fail miserably. And I will share with you in my last talk how they fail, because they can actually fail in a bad way, where multi-organ failure, it's not a heart failure anymore, it's the body failure, literally, with the venous hypertension. So the advantages of the resorting to a Fontan, obviously, we have at least now we have patients who can survive to adult life with one ventricle. Otherwise, it wasn't before accessible or reasonable. So it can be utilized in a wide anatomic subtypes, creates an end-series circulation as opposed to a parallel series. Near normal arterial saturation, most of the time it is normal. Reduced volume overload, because the two circulation are actually separated by venous collaterals, that can confuse all these things, or pulmonary artery venous malformation, which can be also developed. And the cardiac output can be determined by the transpulmonary blood flow. If you hear what's a fenestrated Fontan, basically it's the same tube that we put in between the IVC and the pulmonary artery. We make one fenestration here, and we only use that very sparingly now, only for those patients who have what's called a high-risk Fontan, where we believe they need a shunt to preserve their cardiac output. So we leave this fenestration to allow some of desaturated blood to go into the pulmonary venous atrium, which basically is the left atrium, and then pumped through the systemic ventricle on the expense of a little bit of desaturation, but at least a preservation of cardiac output. And this fenestration, it can be closed later on if the risk factor disappears. This is my last slide, just to show that if you happen to see a patient with Fontan circuit, this is what you have to look at. There are multiple areas that you need to look at, whether you're doing them, we're doing them early, like us, actually creating that anatomical end series circulation, or you're seeing them for a different reason. I was stopped this morning actually by an anesthesiologist who was doing a lap chole in a patient with Fontan, and she said, unfortunately, the general surgeon was doing the lap chole, the adult surgeon, did not know what is a Fontan circuit is, and didn't even understand what the single ventricle is, and spent 5 hours doing a lap chole with a pressurized intracavitary abdominal pressure. This is not good for single ventricle. And I think it's really important for all people who get in touch with those patients later on in life is to understand what their physiology is and how can they optimize their physiology for whatever procedure they need to do. And that's why these patients should be always referred and being taken care of by people who know what that type of the physiology is. Thank you.